Greetings, everybody, and welcome to another UW Osher Center Integrative Health and Cha Chiming Endowed presentation, seminars in integrative medicine. I apologize for a 1-minute delay that we have here. We are going to have a wonderful presentation today on Women's Health series. This is part one of a 3-part series. Today, we're going to talk about thriving through perimenopause, menopause, and integrative approach and empowering approach to health and well-being. I have 2 wonderful speakers with me today. Before we get to the introduction of the speakers, I would like to introduce myself. I'm Dr. Iman Majd. I'm the director of the Osher Center at the University of Washington. I will take about 2 minutes of your time to do a very brief introduction of the Osher Center. Welcome to the ones who have joined us before, and welcome to the new attendees joining us for the first time. So University of Washington Osher Center for Integrative Health. We are a center without walls and clinic without a clinic. We use clinical space within UW clinics, and we have a very small and mighty team who provide integrative medicine. Our goal is to provide a holistic approach, whole person centered, evidence-based care. We do provide care in the form of integrative health consults, acupuncture, naturopathy medicine, and medical massages. Our goal is to partner with each individual in their journey to optimal health, and each individual's well-being is our priority. Right now, we use space at Northgate Clinic, at Factoria Clinic, and UWMC Sports Medicine in Ballard. So they have allowed us to use those spaces to provide our clinical services. There are 10 Osher centers across the country, and they're all being funded through endowments by the Osher Foundation. And there is one in Sweden, Karolinska Institute. And these are all the clinical services that are provided in integrative medicine in these academic centers. We also do have an administrative body called Osher Collaborative that provides some support to some degree when the Osher centers want to work with each other and have collaborative projects. The Osher Collaborative provides that administrative support. I would like to extend my gratitude and thank to the individuals who have been supporting and sponsoring this teaching series, Cha Chiming family, and also Sunlin and Priscilla Cho for their gift. They are big supporters of bringing integrative medicine to public and translating integrative medicine knowledge and science into conventional medicine, bringing Chinese medicine into conventional medicine. And without this support from them, this series would have not been possible. And I want to make a quick pitch here that our operations are very small, so we would appreciate any gifts that anybody feel comfortable to make to the center. That would be very welcome. Any amount is welcome. And there will be a link in the chat that will take you to the page for donations if you feel comfortable making the donation. Thank you. I'm going to introduce our wonderful speakers here, and Dr. Deborah Bell and Dr. Starlin Haas, 2 great speakers. Dr. Bell is the co-director of the education at University of Washington Osher Center. She is faculty at the Department of Family Medicine. She's one of the pioneers in the field of integrative medicine, has done integrative medicine for more than 40 years. I think she started at the time that even the term integrative medicine didn't exist. She is, frankly, an authority in integrative women's health, very well known across the nation, and provides integrative medicine consult at the Ballard Clinic, and also has a practice integrative medicine primary care at Northgate Clinic. We are very, very fortunate to have Dr. Bell as part of our team at UW. Our next speaker is the wonderful Dr. Starlin Haas. Dr. Starlin Haas is a licensed clinical psychologist with health and rehabilitation psychology specialties. Dr. Haas has an extensive experience working in academia and also in private practice. She has a private practice right now called Mindfully Balancing Wellness, supporting people who are faced with various health and reproductive challenges, mental health diagnoses within the context of health challenges, caregiver and provider adjustment, and multicultural consideration. So welcome, Dr. Hawes, Dr. Bell. I am going to mute myself. Dr. Bell is going to take over, and we will enjoy listening to your presentations.
Thank you, Dr. Maj. Hello, everybody. We're going to start with just a brief breathing exercise, which will hopefully get us all ready and prepared for the presentations, and also will be a tool that you can continue to use, that we use for stress reduction. So I invite you to sit comfortably in your chair, try to pay attention to your back being supported and straight, and your both feet on the floor. And if you're comfortable with it, you can close your eyes. If you're not comfortable with that, I invite you to lower your gaze. You can turn your, to away from the screen. And I'm just going to talk us right through it. So we're going to start by breathing in through our nose. We're going to hold our breath, and then we're going to exhale, and I will count us through. So we'll begin by breathing in through your nose. Feel the air moving through your lungs, filling your diaphragm going down, and hold your breath for a count. 4, 5, 6, 7. Now exhale through your mouth, letting all the air come out as if it is a bellows, pushing out through your diaphragm, going up. We're going to count through to 8. And then we're going to start again. Breathe in through your nose. 2, 3, 4. Hold your breath. 2, 3, 4, 5, 6, 7. And exhale through your mouth. 2, 3, 4. You can even have a whooshing sound. 7, 8. And one more time. Inhale. Hold your breath. And exhale. Okay, you can open your eyes. We'll come back to the presentation now, and I'm going to start. I'm going to start with a pitch. Or not a pitch. It's just to let you all know that I'm going to be starting online medical group office visits for perimenopause and menopause through the UW Northgate Primary Care Clinic. And the important thing is that you must be in the state of Washington when if you are going to register, and you also must have the University of Washington primary care provider. It doesn't have to be at Northgate, but it does have to be that. And if you meet those 2 criteria and you are interested, it's a 4 series, so you do need to come to all 4. Starting on June 4th, I will be offering them again in September and throughout the year. You get a referral to me at the Northgate Clinic for menopause group visits, and someone will reach out to you. Okay, so this is the general overview of what we're going to do. And I want to start by just saying that actually first I'm going to set my timer so that I make sure that we all have the time we need to get everything done. That I'm coming from the philosophy. I don't really see it as a bias. I see it as a primary philosophy. The perimenopause and menopause are a normal phase of life, and they're not a medical event at all. And that said, many, many people have significant symptoms that can have a negative impact on their health and well-being. And so we definitely do not want to take the stance that you're just going to wait it out, or that you just pull up your bootstraps, but that actually it's very, very important that we attain symptom relief so that our health and well-being is in a good state. But it doesn't mean that it's a medical event. And so the way that we address these symptoms is from this very broad view of a holistic approach, and we can be quite successful. And with regards to the wisdom of aging, Dr. Hawes and I are using the term empowerment. And empowerment in this setting is that we're going to learn what even to expect. So some of the sense of well-being is just to recognize that this is normal and it's actually not that disruptive. We're just not sure that it's okay. So learning what to expect, learning about ways that we can help ourselves to feel well. And when we learn about those ways, we then can make informed choices and what we call shared choices if we're working with a practitioner for what's best for us to help us with our symptoms. And then finally, and maybe most importantly, I'd like to say a word about the wisdom of aging, because unfortunately, in our culture and the conventional medical view, is that aging is a bad thing and that there are all these negative attitudes that can have an impact on our experience. And certainly in the American culture, there is this sense of older women being invisible and really not taken care of or respected. And this is not a universal view, and it's certainly not a view historically. And so if we can begin to reflect on actually that part of aging includes an experience of life that gives us a great deal of wisdom, allows us to build up an internal beauty, allows us to provide for ourselves and others in ways that we weren't able to do before. And whether that's at our work or with our families or in the community, that actually aging can be a wonderful experience. It can be quite liberating as we get older, in that we don't have some of the responsibilities that we had when we were younger. So I really encourage everyone to start with the idea that actually aging is not bad. And that, I think, is a big challenge for us in our culture. So begin with what is perimenopause and menopause to begin with. And basically what's happening during this time, this phase in life, is that the ovarian function, the function of our ovaries and the activity is starting to change. And perimenopause is the beginning of that change. And it can last for a few months or maybe years. Most people will begin to notice something somewhere in their 40s, and whether or not those are disruptive changes, but they will notice a change. And we even use the term premenopause because some people, when they're in their 30s, even when their periods are not going to stop until they're 50, begin to notice some changes. And menopause technically is 1 year after menstrual cycles stop. And at that point, then the ovaries are really changed significantly in their activity. So the challenge is that no two menopause transitions are alike. And this is a great opportunity for integrative medicine, because the foundation of integrative medicine is taking an individualized approach. And so we're going to address some of those things today from this broad view. But I want to take this moment to say a little bit about the history of addressing menopause, particularly because the public view these days, and definitely in the media, and definitely in social media, is that it's all about hormones and hormones, and everyone should be on hormones. And if we're on hormones, we won't have dementia and we won't have a heart attack. And it's really important for our bones. And everybody will feel fabulous and look fabulous if they're on hormones. And that really, I think we need to understand that that's where our culture is now based on the history. And the history is that prior to the 1960s, nobody would ever consider going to a medical person for the menopause changes. And either it wasn't addressed or it was addressed by the wise women. And some of those wise women were just people in the community and the way women engaged with each other. And some of it were actual people who were healers who were helping people. And the people who did go to the medical communities prior to the 1960s and 70s with these complaints often were diagnosed with hysteria and given all sorts of treatments that, in my opinion, were not necessarily to their advantage. And then we developed the means for taking hormones from the outside and putting them in. And by 1990s, the medical standard actually was to give everybody hormones, because there was this idea that it was going to prevent a bunch of things. And at this point, the hormones were synthetic estrogens and synthetic progestins, not progesterone. And there was a very big study called the Women's Health Initiative study to look at the effect of these hormones. And it was thousands of women. And the study was stopped because they found that there was an increased risk of breast cancer and that the risk benefit was negative for the use of hormones. So the reaction to the medical community was to say, well, we shouldn't be giving people hormone replacement therapy anymore. And there was an attempt to use other pharmaceuticals, which, quite frankly, either don't work very well or can come with a bunch of adverse effects. And people were pretty stingy about offering hormone replacement therapy. And what tended to happen was that menopause symptoms began to be disregarded and overlooked by the medical community. And in the last 5 or so years, people have been speaking out about that, particularly because our resources for hormone replacement therapy have advanced above and beyond these synthetic oral hormones. And there are a lot of choices. And then, and this is my opinion, is that the American way is that more is better and that we want an easy fix. And so in the last 5 years, as people have been raising the awareness that people are not getting their needs met and that hormones are being withheld, now there is this popular view that everyone should be on hormones, which I will be talking about throughout this presentation. So just a very, very brief review of what is happening in the menstrual cycle. And it's important to know that because then it changes. So in this graph, the two orange are estrogen and progesterone. And you can see that the number 1 is the first day of the period. And then estrogen and progesterone are at their baseline. Estrogen begins to rise, but progesterone does not. And the pink there is follicle stimulating hormone, which is the thing that tells the ovaries start to get ready to ovulate. And what happens in perimenopause is that the ovaries are like, nah, we're kind of tired. We're not really going to listen to you. But progesterone, which is a very important hormone here, it's not all about estrogen, is a product of ovulation. So you can see at the bottom here that after we ovulate, we form this corpus luteum, same color as the graph of progesterone, and that's what makes progesterone. So as we get older and our eggs get older and ovulation timing changes or doesn't happen at all, the first thing that changes is our progesterone, and this can lead to some of our symptoms. So these are some of the symptoms that happen in perimenopause, and this is largely from the changes that are happening in our menstrual cycle and what's happening in the ovarian function. And some of us in integrative medicine would describe this as estrogen dominance. And although there are some people who have that based on their own estrogen metabolism, most people in perimenopause, by definition, are going to have some estrogen dominance because the estrogen keeps coming from the ovaries, but without really regular ovulation, the progesterone might be affected. So these symptoms are symptoms that people can have in perimenopause and menopause. And again, some of them are more prominent related to progesterone or more prominent related to perimenopause than others. But the important thing to know about symptoms is about 10 to 25% of people have no symptoms at all, and that some people have all the symptoms all the time. Some people have some of the symptoms all the time, and some people have some symptoms sometimes. And these are quite dependent on other factors. They can be our lifestyle factors, which we're going to talk about. They can be related to stress. They can be related to the time of year, if it's hot outside, if we're traveling, etc. And the other interesting thing about things with symptoms is that people, again, back to this hormone thing, there's this myth that if our hormones are just balanced, we won't have symptoms. The issue is that you could take 10 people who have the exact same symptoms, and they might all have 10 different hormone levels. And the reverse is true. You can have people who have all the same hormone levels, and their symptoms are going to be different. So unfortunately, there isn't a magic number. There isn't some level that we're trying to attain of normality with regards to hormones that will then make the symptoms go away. And similarly, this notion of balance really, although there is something about the ratio between estrogen and progesterone, there really isn't a magic number. So it's not just about our hormones. And a big factor for our symptoms is about our body getting used to the fact that our hormones are changing and our hormones have changed. And some people's body they don't care about the change. And those are the people who have no symptoms. And some people continue to have symptoms for the rest of their life. And it's not just a few years. The average amount of time for symptoms that is reported in the literature is about 8 years. And if you count people who really struggle with perimenopause, it can be longer than that. These are the physical changes of menopause, and some of these things are things that we can change with treatment, but some of them, back to this wisdom of aging, are things that are just reality about normal changes that happen as we grow older. And body fat redistribution is one of them. Many people say, oh my gosh, it feels like everything has sank. And there are a lot of things we can do with regards to that, with our diet, with exercise, and also just what clothes do we wear. And we change how we dress. And the same would be true about our breast shape. How do we adjust our lifestyle based on our changes in our metabolic rate, et cetera? So that brings us to the foundation. And the foundation, this is the foundation for all health, actually, in integrative medicine. And without it, all of the other treatments that we do are not as effective. So and the thing that I wanted to say about this is that really that this is an opportunity, that this normal phase in our life is often a time where we can reassess how we're taking care of ourselves. Pregnancy is another time when people will change their diet, they stop smoking. And I see perimenopause and menopause as another one of these opportunities of what is it about how we take care of ourselves that we might adjust based on how our body is changing. And so all of these things up here are an important factor, and we'll be talking about nutrition. Eating well is not only just what we eat, but mindfulness of eating, paying attention to when we're hungry, when we're full, why we eat certain things, how our body responds to certain things. Exercise is not only important for our metabolism, and of course, exercise is not the only thing around our metabolism and our weight, but exercise does help us with the biorhythms of our hormones and is very important to help us with stress reduction. With regards to coffee and caffeine and sugar, alcohol, those things all will aggravate symptoms. And there are some people who will notice when they modify that, their symptoms are now manageable and there isn't anything else they need to do. Artificial sweeteners, I just recommend that people avoid them. We have more and more data that they are harmful in lots of different ways, and they also can aggravate our symptoms. So let's talk about nutrition here. So there's two phases of hormone metabolism. We call phase 1 and phase 2. And phase 1, particularly for estrogens, is what breakdown products, what metabolites do we make when our body is getting rid of its estrogen, it's processing its estrogen. We make some, we get rid of some. And there are what we would say benign, not harmful estrogen metabolites, estrogen breakdown products. And then there are unfavorable ones that may be associated with the risk of breast cancer and other problems. And so the high lignin foods, which are the ones on the right, and it shows flax seeds, but it actually has to be ground flaxseed, and prunes are the highest lignin foods that can help us with this phase 1 of hormone metabolism. The cruciferous vegetables are very important for phase 2 of our hormone metabolism. And phase 2 is how do we excrete, how do we get rid of these hormone breakdown products. And the cruciferous vegetables help us do that through our digestive tract. We know that cruciferous vegetables reduce the risk of hormone-dominant cancers, which would include breast cancer and uterine cancer. And so the recommendation for cruciferous vegetables is at least 1 cup of cruciferous vegetables daily. You'll see what those are on the left there. And a whole lot of excess cruciferous vegetables is not great for the thyroid. That does not mean that you can't have raw arugula in your salad or kale in your salad or radishes, that you have to cook everything. But what I often say to people is cook when possible. So I'm not recommending that people take a literal bunch of kale and blend it into their smoothie every day. I'd rather that you steam it first and put it in. So cook when possible. The other important thing about nutrition is our glucose metabolism. So if our glucose is going up and down and up and down, when it goes up, the body says, why is the glucose high? Does that mean that there's an emergency? And this can activate the various stress responses that can aggravate our ability to modulate our temperature. It can create inflammations. People wake up and they complain about feeling like their joints are achy like a 90-year-old when they're only 50. And these can be aggravated by having a glucose metabolism that is going up and down. And so our goal is to try and have this steady state of glucose metabolism. And one way we can achieve that is through what we call a low glycemic load diet. I could do a 3-hour presentation just on that. So the catch point is what I call the trifecta of eating, which is half your plate or half of what you're eating are vegetables. And again, they can be cooked vegetables if that's easier for you to digest. You have a protein. I'm going to talk about some plant-based proteins in a moment, and a healthy fat. And the plant-based proteins are wonderful because they're low in calorie and they can have some specific anti-inflammatory properties as well. So this includes snacks, right? If you find yourself you're taking a small handful of almonds, well, maybe you want to have some veggies with that. If you are even having a sweet treat, well, where are my vegetables and my protein and fats? So speaking of plant-based proteins, I would like to say a word about soy because it gets a bad rap in our media. And some of this is because, unfortunately, in America, we have this habit of processing foods. And so soy has become one of those foods that is highly processed and is put into lots and lots of packaged foods as additives. That form of soy lecithin, and other soy byproducts are not good for us. And it is true, they interfere with our hormone metabolism. But what I would consider whole organic soy, and I have a list of some of those things on the left there, those would be things where the soybean itself, the chemical makeup of the soybean, has not been changed. And these things are incredibly helpful for us as perimenopausal and menopausal women. Big myth buster here, soy does not increase estrogen levels. I will say that again. Whole organic soy products do not increase estrogen levels. In fact, what soy does, or the chemical, the isoflavones in soy does, when we have it in the diet, not necessarily in supplements, because again, then you've just extracted out the isoflavones, is that they selectively turn on the receptor of what are called beta estrogen receptors. And those are the ones that help us with our bones and many other things and do not stimulate the breast or the lining of the uterus. And so they can create some estrogen-like properties that are helpful without the harmfulness of other estrogen properties, and they do not increase the estrogen in the body. They also may act as what we call selective estrogen receptor blockers by blocking those other receptors that stimulate the breast and uterine cancer. So soy actually can reduce the soy in the diet, that is whole organic soy, can reduce the risk of breast cancer. The dose that seems to be helpful can be as low as 15 milligrams, which is, a few edamame. A portion of tofu is about 70 to 80 milligrams, which is a nice serving of soy as a daily thing. And we do know that it helps us with all of these things that I have listed here on the right. So now, we started with our stress reduction technique. I want to talk a little bit about stress and how that is a big component here with regards to our symptoms in perimenopause and menopause. Because we have hormones changing, again, the body is saying, oh my gosh, something's happening to my hormones. There must be an emergency. And out goes the emergency call. And some of the emergency responders are things like inflammation and how our energy is and what our metabolism is like and how do we regulate our temperature and giving us disrupted sleep. So that sympathetic nervous system, that fight or flight or fight or freeze is very activated just because we're going through this normal process. And if we have any other stressors, they are also going to aggravate our symptoms. I have a lot of stories of people who are university professors, and when they're lecturing, they start dripping in sweat. I had a kindergarten teacher, her children were very concerned about her. When her face would turn red and she'd start dripping in sweat during story time. There are many different things that don't have to be negative things that just activate that stress response, and our menopause symptoms can be worse. So using stress reduction techniques like abdominal breathing techniques and many, many others can be very helpful to manage our symptoms. I mentioned exercise earlier, but again, exercise, we have this data that it does reduce the activated stress hormones and helps to help the parasympathetic nervous system, that rest and digest. Yoga also, there's lots of good data about the reduction of menopause symptoms for people who are doing yoga regularly. And one short technique is called alternate nasal breathing, which can help specifically with hot flashes. I mention acupuncture here because not because it's only used for stress reduction technique, but just as a place to put it. Acupuncture can be very, very helpful for many, many different symptoms of perimenopause and menopause. It can be very helpful for heavy menstrual bleeding. It can be and irregular periods. It can be helpful for sleep disruption. It can be helpful for hot flashes. And the issue is that some people really have a fabulous response and it stays that way. Other people find that even if they have a response, they have to keep up their acupuncture on a regular basis. That is difficult. And that's when we start to look at other tools in addition to all the things I've already mentioned. And so that might be herbs and supplements. Now, I'm already a little over 20 minutes here, and we still haven't talked about hormones. So I don't have time to tell you about all the herbs and supplements, but there are some few that I'll mention that we use for primarily for hot flashes and night sweats and things like that. But there are many others. Do know that herbs can be used synergistically. They work well blending with each other. And if you're going to try something on your own, start with something simple. And that is also assuming that you don't have any other medical problems. And if you're not finding a good result, then consider meeting with a professional who knows about these things, an integrative medicine practitioner or someone else who's trained. And I don't consider the clerk at the health food store to be one of those professionals. That's a little bit of my pet peeve. So let's talk about some of these herbs somewhat quickly. Black cohosh, extremely well studied. Another myth buster. It also does not increase our estrogen. Can be very helpful, particularly for hot flashes, but also for mood. And we do have scientific data to show that it's safe for people to use who have breast cancer. Ashwagandha is in the category of what we call the adaptogens, helping the body to adapt to change. Well, that's what we've been talking about. That's what's happening in menopause. Can be very, very helpful. It's a really nice one for perimenopause and works well in conjunction with other herbs. And then Vitex is also our perimenopause, but also menopausal herb to use because Vitex helps to support that luteal phase, that second half of the cycle, which is the thing that is struggling a little bit in perimenopause. We have evidence that it has been used since the time of ancient Greeks to help women. And black cohosh is native to the Americas and North America and has been used by indigenous populations for centuries to help women with symptoms. Okay, I'm already at 25 minutes and here we are at hormones. So I just want to say a few words about that and then we'll move on to Dr. Ha's presentation. We use the term bioidentical hormone. That means that the hormones have the same physiologic chemical structure of what women have in their bodies. And this is still made in a pharmaceutical factory. And usually the products they start with are natural products. We have lots of different ways to administer it. And what we did learn from the Women's Health Initiative study and from studies after that, oral estrogens are not a delivery system that we want to use in menopause. So here are our players. We have 3 estrogens. Estradiol is the one that will be in the standard pharmaceutical patch. But if we use a compounding pharmacy with a professional who's well trained, they can put in whatever hormones they want. A word about progesterone that unfortunately in the conventional medical world, the term progesterone is used equally when they're talking about those progestins, those synthetic progesterones, and those do not have the same support for us at all. In fact, the only thing they do is protect the lining of the uterus that progesterone does. We don't have time to talk about testosterone or DHEA in detail, but I will say that these are actually two hormones where I would look at hormone levels, because if the hormone levels are not low, the person is not going to benefit and it might be harmful. And even if they are low, you do all of the other things first, because a lot of times people don't really notice a change in their symptoms even when they're being supplemented. So all of the hormones are related to each other. So if we change one, we have the ability to change the others. And this is my final comments, is that in my opinion, the reason to use HRT is to help with the treatment of symptoms. And we do that. We do that a lot, but it's not necessarily the first line, depends on the person. And it is not to prevent anything. So we have now been looking at hormones for 40, 50 years, and we keep trying to come up with these studies that show that it prevents this and that, and they're still inconclusive. And I'm coming from the philosophy that half the human race was not created in a way that when we get to a certain phase of our life, we need some kind of pharmaceutical to help us to survive. And we do sometimes need it for symptoms, but we do not need it to stay healthy. All of those other tools that I just talked about, we do have evidence that that helps us. And we don't have evidence that the other prevents anything. And again, we might be very specific as to which area we're going to treat. So there's my summary. And there is one more slide that when you go to, if you like to look at these slides again in more detail on the website where they'll be posted, there is one slide that divides up symptoms that might focus a little bit more on which hormone for people who are thinking about hormone replacement therapy. And again, if you are in Washington and you're part of the UW primary care system and you're interested in my group visit, I would welcome you to join. And with that, I will pass it off to Dr. Hawes.
Just a few disclaimers quickly. Want to make sure everyone knows therapy or clinical advice won't be given today. And just a reminder to reach out to your qualified healthcare provider with any questions that you may have. Second bullet is just a friendly reminder that information does become outdated at a certain point. And last but not least, even though this is brief, the presentation is meant to hold space for everyone. With that said, we are missing out on important health education, and that is a big reason why we're here today. Only 6% of recently surveyed women felt prepared for perimenopause. 69% don't recognize symptoms, and 92% want more education. However, we are well aware that 100% of us will experience perimenopause and eventually menopause. So let's talk a bit about what this transition could look like. Imagine waking up one morning and not recognizing what's happening with your body. Yesterday, you felt great. You were walking in your power, and you were having the kind of day where you were thinking, bring it on, because you knew nothing was going to derail you. Then, that night, you fall asleep peacefully until suddenly you're hot, but not just regular hot, like heat rushing up from the inside out. You're sweating, restless, throwing off the blankets. Minutes later, you're cold, so you put the blankets back on. You finally get back to sleep, only to wake up drenched, your heart racing, your sheets soaked from all of that sweat, and your body confused. You wonder what's happening. Is this a one-time thing or something more? For many women, this is an example of how perimenopause begins without warning, without a roadmap, and often without the support we need to understand what's happening. I'm Dr. Starlin Hawes, an empowerment health coach and a licensed clinical psychologist. I specialize in health and rehabilitation psychology and really support women navigating this life transition through an integrated, holistic approach. And I'm here to tell you, you don't have to do this alone. So here's our roadmap for today, so you'll have a sense of what will be covered. So what's really going on during perimenopause and menopause? Let's take a look at this visual. On the left, you'll see hormone patterns during 6 months of regular menstrual cycles. Regular does look different for everyone, but this is what we refer to as the premenopausal phase. The middle image shows perimenopause, and this is often called a hormonal roller coaster. It typically begins in the mid-30s to late 40s, but it can start earlier due to genetics, health conditions, or medical treatments that affect the ovaries. You see that estrogen, the dark green line, is all over the place, and that's a part of the reason that women develop symptoms like hot flashes, night sweats, mood swings, brain fog, and the unsettling feeling of not quite recognizing yourself. Menopause is defined as 12 consecutive months without a menstrual period. After that, you're in postmenopause. And this is where estrogen and progesterone remain at a low, steady level. To be clear, once you're in menopause for the rest of your life. And this is what's also referred to as postmenopause. But it's important to know this transition isn't just physical. Your mind is going through changes too. It recalibrates each time your hormones aren't following a rhythmic, predictable pattern. And this is part of the reason why symptoms develop in perimenopause. The science is clear. During this time, your brain and body are navigating a complex shift. As your hormone levels rise and fall, your brain is adapting, trying to evolve in ways that support you in this new phase of life. This process impacts both our physical and emotional well-being. Our reproductive transition from puberty to menopause is a natural process. Suffering is not. Everyone's path through menopause is unique. Symptoms don't happen in a specific order, and they don't always make themselves obvious at first. Far too often, it's not talked about. Worse, many healthcare providers report not feeling fully prepared or trained to adequately support women through the menopause transition. And that can leave women feeling confused, isolated, and misunderstood. To gain a more well-rounded view of what's going on during menopause, let's look at it through the biopsychosocial model. This slide has a lot of information, so please bear with me. As a health and rehab psychologist, and also in my work as a coach, I use this model to understand what people are going through. In short, you're a whole person with many parts of your life affected by this transition, and you deserve care that reflects that. Biologically, the hormonal ups and downs during perimenopause and menopause can lead to a wide range of physical symptoms. Some might be silent, like shifts in blood pressure or bone density. Others are subtle, like changes in your menstrual cycle or how your body handles insulin. And some are disruptive, like joint pain or poor sleep. Psychologically, this stage of life can bring mood swings or trigger symptoms of anxiety and depression. Many women also describe brain fog, scientifically known as mental fatigue, which also affects how you show up at work and at home. Socially, menopause still often has stigma surrounding it. Thankfully, more conversations are happening now, but there's still a long way to go. Whether it's in your relationships, at work, or with your healthcare providers, many women still don't have the information or support they need to feel confident during this time. Now, it's important to understand that race and culture can shape how women experience the transition through menopause. Along with everyone else, white women tend to experience hot flashes, mood and weight changes, and sleep disruption. However, research shows that Black women often begin menopause earlier than white women and tend to report more intense symptoms. They also face higher risks for issues like heart disease and sleep problems. Similar to Black women, Latina women also tend to enter menopause earlier than white women. On average, they experience hot flashes for about 8.8 years, longer than other groups. However, Native American and Black women experience them longer. Many are the heads of their households, juggling multiple responsibilities, and may not seek support or even realize it's available. In some communities, menopause is seen as something women are expected to handle quietly, without complaint or outside support. Asian women may experience more symptoms related to muscles, joints, and the heart. Cultural values around aging and keeping certain struggles private can also affect how menopause is talked about or not talked about within families and communities. Unfortunately, the women who may experience the most severe symptoms are often not represented in research studies. For example, Native American women may face the longest and most intense menopause symptoms, but there's very little data to fully understand their experience. The earlier you go through menopause, the earlier your body begins to go through changes, like reduced bone density, increased body fat, reduced muscle, and higher cholesterol levels. That means health risks like heart disease, bone fractures, and falls may show up sooner too. No matter your race or cultural background, we each deserve support, information, and respect as we go through this life transition. The more we know, the more we can care for ourselves and each other. It's understandable that uncertainty or changes would lend to concerns and or mental health challenges. If you're someone who's had a mental health condition in the past, like anxiety, depression, or mood swings, even if they were stable or had gone away, perimenopause and menopause can make them harder to manage or bring them back. And if you've never had a mental health issue before, this stage of life can sometimes trigger new symptoms that look like anxiety, depression, ADHD, or even memory problems similar to dementia. In some cases, you might receive your first mental health diagnosis. It's important that healthcare and mental health providers understand how much hormones can affect your mood, focus, and brain function. That way, your treatment plan fits your needs. Why does this matter? Because if your symptoms are assumed to be a mental health issue only, your provider might offer the usual medications for depression or anxiety. Sometimes that's exactly what you need, but if your symptoms are linked to the menopause transition, you may also want to explore hormone replacement therapy as an option. Some women find that a mix of both treatments works best for them. And at the same time, you always have the right to say no to medication or hormones. If that's your choice, be sure to ask your provider about other treatment options like therapy, lifestyle changes, or natural remedies. Just in case it's helpful to know, a recent study found that 54% of women who did get therapy during this time very much found it helpful. And here's the thing, if they were working with menopause informed providers, I imagine that number would be even higher. So what can you do about all of this? Self-care matters. Earlier, we talked about the biopsychosocial model. And in that model, there are some factors we can't change, like age, genetics, and ethnicity. But there are also modifiable factors we can influence, like what we eat, how we move our bodies, how we manage stress, how we sleep, and how we set boundaries for ourselves. We can empower ourselves through knowledge and intentional action. So, for example, regular exercise can ease hot flashes, improve mood, reduce anxiety, and it can also help us sleep better. Meditation and mindfulness can help you stay grounded during emotional ups and downs. Healthy boundaries and redefined goals can help you adjust as your identity and needs shift. And remember to tap into your support system. Your village might be just what you need. You can also seek out support from a mental health provider or a health coach who's informed about perimenopause and menopause. Meeting with a coach can be helpful when you don't have mental health diagnoses or you don't particularly want to work with a mental health care provider. Complementary approaches like acupuncture or massage therapy may also support you. This is a time to lead with curiosity and self-compassion, not self-judgment. There's more than enough stigma around this already, so try not to add to it by being hard on yourself. And remember, you bring strengths to this experience. Try to tap into them. You don't need to perfectly manage every moment. This process will ebb and it will flow. But over time, you may find yourself riding a wave with increased ease. During perimenopause, many women are juggling a lot. If we're working, we're often at the peak of our careers. At the same time, we might be raising young children, which is very different from parenting in the empty nest phase. We might also be caring for aging parents. And in 2022, 80% of women said menopause symptoms burdened their family life. So here we are, juggling all these things, and we're still thinking about how we and what we're going through is a burden to our family. It would be understandable if you said, hard stop. I need to reassess, and whatever you need that to be. Feel free to take a moment and think about what you might need that to be. Work is also important. And for those of you who don't have traditional careers, that work matters too. Work can also be challenging. A 2024 study found that 79% of women were concerned about sleep issues, and 78% were struggling with brain fog, concentration, and memory. In addition, 1 in 4 women didn't pursue or considered not pursuing leadership. 1 in 3 reduced or considered reducing their workload. And 2 in 5 considered changing or changed jobs or their career ambition due to this time in their life. So perimenopause and menopause affect more than our personal lives. They impact our professional lives too. Symptoms can make it tough to stay focused, be productive, or even get through the day. So some strategies that can be helpful at work and in general: prioritizing sleep and practicing good sleep hygiene whenever you can, breathing through brain fog. Brain fog can trip us up and make us question ourselves. So if your brain isn't cooperating, try taking a few deep breaths, pause, and try to figure out your best next step. You might consider using note-taking apps for task and project management to give your brain a break and ensure you've got what you need, where you need it, when you need it. This would also be a good time to consider graduating from multitasking. You can also strategically use breaks to hydrate, eat, stretch, take a walk, and address other care needs. This might also help you gain a better pace for your day. Hot flashes are a whole different category. For those, dressing in layers so you can adjust, keeping extra clothes on hand in case you need to change, packing cleansing wipes and deodorant, maybe wearing your hair up or having a hair tie, and avoiding known hot flash triggers like spicy foods. For some people, it's caffeine. There are others. A cold pack or a hand operated fan is not a bad idea either. If these strategies aren't enough, you might want to ask for accommodations. Some organizations are menopause friendly, so you can just check your manual, see what's there. If not, you can make some requests, sometimes tagging your healthcare provider to support you on that front can be helpful too. Let's take a moment to talk about the importance of partner support during this transition. It can feel isolating, and having a partner who's tuned in and supportive can really make a difference. Before I dive deeper into this, I want to address the partners who might be thinking, I don't even recognize my partner anymore. Here's something you might not know. Your partner might not recognize themselves all the time either. It's not uncommon for women to feel like they don't even know who they are during this time. For those of you feeling this way, you're not alone. And here's a quick explanation. Your brain is essentially being remodeled during menopause to support you in this new phase of life. This remodeling is something that some women breeze through, and for others, it can feel mildly to severely disruptive. In fact, in 2022, a study found that 73% of women said that menopause contributed to relationship challenges or even divorce, and 1 in 5 sought support but didn't initially realize how menopause was impacting their relationships. So this might be helpful to keep in mind. If you're in a relationship, open and honest communication with your partner is important. Ask for emotional support, whether it's a hug or a listening ear, or just understanding. You might be a little more irritable than usual. You might start by naming that you've been experiencing changes due to perimenopause and that you'd like to see how you can come together and support each other through it. So a few topics that might be helpful are learning about menopause together. It might be helpful to note that you realize your partner is impacted too. Maybe talking about your mental and emotional load, and even changes in physical intimacy. Some more support can also mean asking your partner to go to doctors, coaching, or therapy appointments. If your partner learns about this transition alongside you, they'll be better equipped to support you in the long run. Remember, this is an opportunity to turn towards each other. It can strengthen your relationship and help create more compassion and closeness. So, doctor's appointments are important. You're going to have a number of them. On average, women see 4 doctors before receiving helpful menopause care. Often women feel dismissed. Sometimes symptoms are brushed off as just aging. And while aging does play a role, menopause-specific symptoms still deserve focused attention. So a few strategies to help you get through your doctor's appointments or prepare for them are writing down your symptoms, knowing how often, intense, or how long they last. Also, preparing questions ahead of time. Appointments are brief, so this will help you get the most out of it, as will having priorities for your appointment. During your doctor appointment, being able to ask about treatment options is helpful because one size fits all does not apply here. Medication may help, but it might not be enough on its own. So asking for a menu of options and knowing the pros and cons of each can be helpful. If you have done some research, consider bringing that. Ask your provider to help you understand it or even weigh in. If you want to make decisions together with your provider, make sure they're on board. You deserve to have a voice in your care. If your current provider isn't knowledgeable about menopause, it's okay to ask for someone who is. And I'm going to make sure you know that you deserve care that sees you, listens to you, and supports you. Seek that care because it's out there and you are worth it. And my last slide here, because I know we're getting short on time, I just want you to realize that this presentation really only scratches the surface. This is a complex transition and there's so much more to learn. My hope is that today sparks some curiosity, clarity, maybe even a bit of relief. Please remember that this transition is unique to each person. The more you're able to notice what's happening in your body and mind early on, the more empowered you are to seek and improve your outcomes. Yes, on some level, this can feel like it upends who you thought you were, but it's also an opportunity to redefine who you are today and how you want to show up for yourself and the people you care about. So again, you don't have to do this alone, and you absolutely deserve care that's thoughtfully tailored to you. If you'd like to stay connected, learn more, or ear care, I have included my contact information here. You can either scan the QR code or type in the web address. Thank you again for being a part of this important conversation.
Thank you so much, Dr. Haas and Dr. Bell. And there are some questions that I would like to address. And I personally learned a lot about menopause. It was very informative. Also needing to mention that men also will go at some point through the andropause, but later maybe in their 70s and 80s. And I don't think that they will be suffering as much or dealing with these conditions as women have. So it's good to have awareness around these conditions. And I really like the approach that you both had, kind of acceptance of this phase, not necessarily looking at it as a medical condition, kind of trying to embrace it and work with it, and addressing the fact that everybody will be different in this journey and it's not a one prescription for all. So there are some questions here. The first question I think is for Dr. Bell. Many women after 40 years old, they start having some changes in their body, including weight gain, redistribution of weight, and difficulty losing the weight. In your opinion, are they related to the hormones, and what can be done to minimize these effects or actually improve these conditions?
Yeah, I mean, so one of the physiologic changes that does happen is that our basal metabolic rate changes. And then, as I said, that if we have lots of stressors, either regarding our symptoms or what happens to be going on in our life at that time, or even just that we've begun to have sleep disruption, that's enough of a physiologic disruption, is that the body then decides it needs to conserve, because the stress response is there's an emergency, I'm going to have to run for my life, and I'm going to conserve and get ready. And so there are lots of things that we can do. So the big one is, what are all these stressors? How is my sleep? How is my mental health? What's happening in my relationships? How do I feel about myself, etc.? And then some of the dietary things, I think, again, the foundation is learning what our metabolism is now that we've had these changes. And so, as Dr. Hawes talked about, curiosity, we just begin to reflect on, what are the things where my body feels good? What are the things that I notice? Many people will say, oh my gosh, I have one cookie and I gained 10 pounds. What might I do differently? And again, not that you have to have a lot of restrictions. It's just you have to learn what kinds of things we need to do to change that. And I think, how we go about learning to make those changes are some of the things that Dr. Hawes talked about and what I was talking about self-care and mindfulness.
Is it okay if I add a little?
Yes, please.
Please.
Soundbite? I think one thing that's really important for us to know is you can have these changes even though you've changed nothing about what you're putting in your body, how often you're moving your body. So it's important to have providers who can normalize that part of it for you and explain it to you so that you can come at it from a different vantage point and maybe have a little more grace and patience with yourself and the process.
Exactly. I can't tell you, probably thousands of women who come in to see me sometime in their 40s or early 50s who say, I'm eating well, I'm exercising more than I ever have, and I'm gaining weight and I can't lose it. And that is just a very common thing that happens. And again, we're not stuck with that we're just going to have to be 10 or 20 pounds heavier than we were. I think that actually it's normal to be 3 to 5 pounds heavier from when you were 32 to when you're 55, and that is acceptable. That's a normal change. And more than that are things that we can explore to figure out how to stop continuing to gain weight and how to deal with all of the various aspects of our lifestyle to meet with where our body is at this phase in our life.
Wonderful. Thank you. And if I may add a little bit here, you both mentioned regarding mindfulness, exercise, being present, and taking care of individual, taking care of ourselves. I'm including myself here in this conversation as well. You're taking care of ourselves. One thing that you mentioned, Dr. Bell, was the adaptogens. When you were talking about the herbs, you mentioned adaptogens, ashwagandha. So one of the big hormones here is a big player is cortisol. The cortisol actually does cause a lot of fat redistribution in the body and weight gain. And it's really important that the stress that's causing by perimenopause and menopause, when people stress too much about this, that the cortisol level will go up. And then we get into this cycle that I'm stressing about something, I'm producing more cortisol. Cortisol is causing more inflammation in my body. I have more symptoms and I'm gaining more weight. So at some point, we have to break this cycle. So here comes the diet, the nutrition, the awareness of the condition, moderate exercise, and kind of like maybe modifying the diet if it's not the best diet and getting help. So just wanted to mention that the more one stresses about a condition, the more cortisol we may produce. And the role of these adaptogen herbs, including ashwagandha, is to balance that cortisol. But again, ashwagandha it may not necessarily be the right adaptogen for every single individual. You have to see who the case is. Great, thank you. My next question is for Dr. Haas. Dr. Haas, we would like you to put your psychologist hat on and tell us a little bit what puts people at risk for mental health challenges during the menopause transition.
That is a good question. And I know I touched on it a little bit, but just to give a little bit more context, there are actually 3 windows of vulnerability that we experience. The first being puberty, the second being pregnancy, and you might have guessed perimenopause as another. This is where hormones shift more rapidly. So for individuals who may have experienced premenstrual dysphoric disorder in puberty, they're going to be more likely to experience depression and anxiety in perimenopause. Those who have a mood or anxiety disorder related to pregnancy or postpartum, same thing. Even a person who hasn't had a history of severe anxiety, experiencing hot flushes and night sweats can increase the odds of having anxiety. For example, people who have a history of things like abuse and neglect or family problems or poverty are also at increased risk during this time. We can talk more about hormones, but I know time is brief. So what I'll say is, even though there are all of these additional risk factors to consider, many of the strategies we talk today hopefully help you feel like there's an opportunity to actually do things for yourself to better support yourself. If you know what to look for, then you can reach out for help sooner and your outcomes can be better. So.
Yeah, and the one thing that I would add that I often say to people is that in this whole question of like, do I need hormone replacement therapy, is that for some people it can be helpful. For some people, it's just the explanation for what kind of flipped the switch to contribute to our symptoms. And so I think that's something to work out with an educated professional, but also it can be comforting to know, why is this happening to me? That concern of just feeling like why are you having this experience of these moods or brain fog or whatever? It can add to the problem. And if we can understand that the thing that sort of got it going was this substantial change, and that this is something that happens and that we can address, that in and of itself, by normalizing it a bit, can help us in the journey.
Wonderful. So we don't have much time, but I want to have 2 more questions, actually, if you can keep it very briefly. The next question is actually tied to the same question I asked from Dr. Haas. The second part is, how do we make it more normal to have these conversations with others? You mentioned the study that people who actually have the symptoms or need help or maybe it was Dr. Bell, are less included in the studies. So how can we normalize having these conversations in the community with partners and even one with themselves to kind of like having this internal conversation going through this period?
Did I jump in or does Dr. Bell want to?
Then go ahead, Dr. Haas.
Okay. First off, you get to decide when and under what circumstances you want to talk with anyone about this, right? It's your journey, your choice. But you can talk with friends, family, even your children, healthcare providers, whoever you want. With family and friends, it's perfectly fine to let them know you're going through something that's throwing you off. And you can ask them if they have the capacity to listen or even offer support versus just diving in. Once you have the green light, though, feel free to consider sharing that you are going through perimenopause or you think you might be going through perimenopause. And it's really okay to invite them to learn about it with you. When you do that, it helps you speak the same language and you might feel more seen and supported. The only other thing I'll mention is I think healthcare providers can play a really helpful role by normalizing this, by routinely asking patients about perimenopause and menopause. Offering education and appointments might be brief, but sending them with resources that they can look up outside of the actual appointment can be helpful too.
Wonderful. Thank you. So there's an element of acceptance here that going through menopause, perimenopause, and menopause is not going to make me any less woman. So it is a normal process, and I should have this conversation. Dr. Bell, the next question is, are the suggestions that you had here applicable to someone with premature menopause, history of breast cancer, or menopause from surgery or cancer treatment?
Yeah, I think that all of those components are a further other thing to appreciate when we think about an individualized plan. So all of the things that we've talked about, well, except for maybe how we treat it with if we're going to use herbs or supplements, but all the lifestyle things are applicable. It's just that under these other circumstances, we may need more. So again, going through cancer treatment, knowing that you've had cancer, the process can add stressors both emotionally and physiologically that we have to address specifically for that. Similarly, for people who have menopause long before they expected it, people who have surgical menopause when the ovaries are just not there to be there for feedback, those can add additional things that need to be addressed. And I think that the point here is that, as you said, Dr. Maj, there is no one size fits all, and that it is important to know that there are certain things that you don't want to do in terms of treatment, not the lifestyle things, but treatment, if you have these additional factors in your health. But all the lifestyle things and all the other things that we talked about, exercise, mind-body things, are just as important and maybe even more so, given that there might be added stressors.
Is it okay if I add one little nutshell?
Sure, please.
A medically induced menopause is different than a natural perimenopause process. And so I think that for both you as the individual who might be experiencing it and for the providers who are treating you, it is exceptionally important to have the education that the symptoms associated with that might be, and very much likely will be, pretty abrupt. Yeah. So preparing you for that so that you know what your plan is, and you've hopefully been able to do that in collaboration with your healthcare team. So
yeah, that's a really good point. Really
that's an excellent point. Great. Thank you so much. It was a wonderful session. Thank you for the audience for the question and staying with us. And this, as I mentioned before, this is the first session of this 3-part series that we have regarding women's health. And number 2, number 3 will happen later. So kind of stay tuned, watch for the email coming. And in the next sessions, you'll have more opportunity for asking more questions. So with that, thank you very much. And I hope that you enjoyed the rest of this beautiful day in Seattle and Washington. Until next time, you take care. Bye.
Bye-bye. Thank you.